Can everybody hear me?
Yes, we can hear you.
Okay, great, perfect. I can hear you too. I think we'll give everybody about 30 more seconds and then we'll go ahead and get started. Okay, got lots of folks on. That's fantastic. Welcome and happy Friday afternoon on the cusp of a holiday weekend. So hopefully everybody has plans to rest and recreate with family and friends. I have just a few comments to make and updates to share since we met last time. And then I think we'll open it up to questions that people have. So we'll talk about COVID numbers and just update everybody on our statistics, including cases, vaccinations, and variants. And then we have a couple of non-COVID updates, which we feel like are worth sharing. And myself and Dr. Zweifler will talk about pain management and some of the pain clinic closures that may affect your practice. I'll just touch on an environmental health issue that we dealt with this week, just to highlight how important the work of our environmental health division is. And I think what it will do is we'll actually have them come back for a deeper dive into some of the great work that they do, because it really helps prevent a lot of health effects in our community. And finally, we'll touch base with where we're gonna go with this meeting, just in terms of future topics. And then we'll open it up to questions and answers. So in terms of COVID numbers, I think things are looking pretty well. Right now, we're at 102,413 total cases. We're still adding a few dozen every time, but it's generally slowing down. Whenever the state shared the blueprint metrics with us, we still remain in the orange tier. However, one of our metrics, the test positivity, actually fell low enough to meet the criteria for the yellow tier. Which is reassuring. The way that the state is planning to do the blueprint, that system is actually going to end on June 15th. And so it really doesn't matter as much what color we're in, and it won't matter at all after June 15th. What the state is saying is that this blueprint for safe reopening will be retired, and something much simpler will be in effect, and they're calling that beyond the blueprint. And in fact, when I send out the notes, I'll send you the memo that the state sent. It's actually a very short memo, which is very uncharacteristic of the state, but they basically just laid out the very bare bones of where they want to go. So let me just summarize what they're saying in terms of what to expect afterwards. Not that this will affect your medical practice as much, but I think, as members of the community, certainly this will affect other aspects of our lives. And you are going to be fielding questions from your patients, relatives, friends, neighbors about this. So after June 15th, there's no more colored tiers. We're not going to talk about being in the orange or being in the yellow. And after June 15th, there actually won't be any social distancing for the vast majority of different sectors. They're still working on the schools and higher education piece, and they've really been mum about what hospitals and clinics need to be doing. And so we're still waiting for the state as well as OSHA to come out with rules related to workplaces, especially healthcare workplaces. But for the most part, retail, restaurants, movie theaters, parks, etc., no more social distancing. Masking and face covering really will be expected whenever people don't have vaccinations and they're indoors. Whenever people are outdoors, masks will not be required pretty much across the board. The only exceptions will be if there is a large event with a lot of people that are crowding together, and social distancing can't be achieved and just naturally, and there's not a lot of good ventilation, then they're saying that, that's when outdoor masking may be required. But honestly, I don't know how they're going to be able to enforce that. I know locally, there's just going to be no way for us to enforce. We're having trouble masking right now. So, whenever the rules are even more lax, it's going to be really hard to try to enforce that. But that being said, with the numbers coming down, with our rates coming down, with COVID being less prevalent in our population, the risk that, you have uncontrolled outbreaks is just that much lower. And so that's what's allowing a lot of these restrictions to get lifted. The state is really still.
I think it is a thing of the past. What I'm seeing right now with the 111 the last 13 games, I really like. How about you?
Hello, sorry, is somebody talking, or is somebody trying to ask a question? Okay, sorry about that. Like I was saying, that's what the Beyond the Blueprint means for in general, and the state will have more information, especially from Cal OSHA, about what to do with workplaces. I worked in the ED last night. The most common question I got was about the masking. In our emergency departments, in our hospitals, we're still adamant about doing masking, especially N95 masking and eyewear, and making sure everybody is protected, which is very appropriate. But again, it does beg the question that if COVID prevalence goes down and down and down, at what point do we switch over and adopt a little bit more lax rule for what to do with PPE? I don't know the answer to that right now, and I really haven't seen the state comment on what to do with healthcare settings in terms of being able to lift some of the restrictions. I think the screening can actually be simplified, and that temperature screening can probably go away. Honestly, we really thought that this was going to be a great way for us to filter out people who are sick, or those asymptomatic infected people. But honestly, the temperature screening has not been high yield at all throughout the pandemic. And I think that common sense dictates that we can probably leave that behind. And we're just hoping that OSHA agrees with us so that we can actually make that a legitimate recommendation / requirement for all workplaces, including healthcare workplaces. So we've heard your concerns. Please keep your questions and concerns coming. We do need to talk about this. I just hope that we can give everybody answers in a timely fashion. But the reason that we're waiting is because we don't want to put something out there and then in the first week of June, Cal OSHA come back and really create a lot of confusion by stirring the pot. So right now we're just saying, let everything be as it is. Let's wait for the Cal OSHA workplace standards to get accepted. Let's wait for CDPH to say what they're going to say about this Beyond the Blueprint period. And then hopefully throughout the month of June, we can actually craft what our healthcare sector should look like, what our workplaces should look like moving forward, with the numbers continuing to decline as they are. In the meantime, we got to get our folks vaccinated. We really, it hurts my heart whenever I see that healthcare workers are not accepting the vaccine, and that some of our workplaces still have healthcare workers that are on the fence or not accepting the vaccine. So I think we really need to innovate, the same sort of general public incentives that are happening. I think that there is some room for us to innovate and possibly incentivize vaccinating healthcare workers. And I think as healthcare leaders, we should really be thinking about how can we really just nudge people to do the right thing, go in the right direction, and go ahead and get this vaccine, whether that means just having more educational or in-services, whether that means actually having material incentives that would nudge some people to go ahead and get the vaccine. Whatever it takes, we really got to push people to go ahead and get vaccinated, because it just makes things so much simpler. It protects them. It simplifies the way that we do contact tracing and quarantine and isolation. And it keeps our communities that much safer, because those people are no longer at risk for passing on the infection, either within their workplace or in their homes. What else? MMWR just came out with an article related to vaccine coverage, and then they basically just broke down how the vaccine uptake was going week after week from December all the way to April. And they basically showed that, you know, the people that have the highest vulnerability just from a social determinants of health standpoint, unfortunately have the lowest vaccine uptake. In some respects, that's not surprising because those people also have barriers like transportation and language and time off from work that actually prevent them from going to a vaccine clinic and just getting a shot. But it's disheartening. And I think it is going to be a wake-up call for us to say, we really do have to double down, as we are doing in California and here in Fresno, to try to reach that high vulnerability quartile. And so I'll be sharing that MMWR CDC article that just came out. I don't know if Joe is on. I'll just start talking about vaccines, but if Joe is on, maybe he can jump on and fill in any gaps in what I'm sharing. In terms of total number of vaccine doses administered, we are at almost 800,000 total doses administered. That is fantastic. Remember that includes both residents and non-residents of Fresno County. So in terms of the number of actual Fresno County residents that are fully protected, that is actually a little bit lower than that number would suggest. And that number is closer to around 500,000. Still pretty good, you know, it's still reason to be very, very optimistic. It's really right at like 420 to 450,000 of people that are either fully vaccinated or partially vaccinated. The number of eligible residents is approximately 858,000, and 48% of them, 12 and older, have gotten at least one dose. We'd like that number to be about 60 to 70%. So we know we still have a couple of 100,000 more doses to give before we can really exhale. And so we're really trying to push as hard as we can, but it's hard. You know, the demand has really fallen off. It's interesting, nationwide, the demand for vaccines did uptick a little bit right after the CDC announced that, you know, masking would be radically changed if you were vaccinated. And we're hoping that the same uptick will happen after the governor's announcement yesterday that there's going to be lotteries and other incentives that will encourage people to get their vaccinations. So we really are trying to get people vaccinated. We're making progress, but it just feels slower than it should be. So that's a little frustrating. However, Joe and the team are doing a fantastic job just trying to be innovative, trying to think outside the box. Really, we're demobilizing a lot of our mass vaccination static events and sites and really trying to get out into the community to host like pop-up events, one-day shot events with the Johnson & Johnson, working with faith-based organizations and civic organizations and different businesses and restaurants and even some bars to just host clinics wherever the people want to be congregating, so that we can really lower the barrier of transport to a vaccination site, and then just kind of be in their face wherever they are, and then just really try to get them to take up this vaccine as much as we can. So if there's other things that we can be doing, or if you have some creativity in this space and you have some ideas about how we can be vaccinating more effectively, then we certainly want to hear from you. Please reach out. And I'll just stop there and see if there's any comments. Those are all of the COVID related issues that I'm going to talk about. So I think it's a good stopping point to see if there's any comments or questions about any of those issues. Okay, let me move forward to talk about a couple of other issues. One thing that happened about a week ago, which we're still trying to kind of piece the puzzle together, has to do with a chain of pain clinics. These are pain management clinics that went by the name of LAGS Medical Centers, and they had several dozen clinics in many different counties in central and coastal California. And those several dozen clinics were operating with approximately 30,000 patients. We don't know exactly how many patients were in Fresno County. My colleague in Madera County, Dr. Simon Paul, also is dealing with this issue. and a lot of the Central Valley counties are dealing with this issue. But something happened which prompted the state to intervene, and basically the fallout from that. And again, there's different stories, but the fallout from that is that the LAGS clinic told all of their patients that they had to shut down, and that they were given 30-day prescriptions for their pain medications, and then told to go back to their primary care doctor and follow up. So we're still piecing together exactly what happened, but nonetheless, this has really caused some ripples and waves here in the local community. It's gotten the attention of other state agencies, and they've put out an advisory just related to pain management. I think that this really gives us an opportunity to talk about this whole other kind of, set of epidemics related to pain management, opioid use disorder, et cetera, which we won't do a deep dive into today, but here's what we're doing to try to react to this situation. So we've had meetings with some of our partners in the behavioral health side. We've had meetings with some of the insuring networks locally, and we're planning to have meetings with our state partners as well. The state has actually sent a list of resources that might help patients that are kind of left out to fend for themselves, or primary care doctors that are just left with without the resources that they need to take good care of these patients. So we'll be sharing out that set of resources as an advisory. In the meantime, we're also just trying to teach ourselves, like, what are the pain management priorities that might come commonly with this space. And Dr. Zweifler and I are working on kind of a longer pain advisory that we're going to release next week. Not that we're pain specialists. I mean, I will humbly submit I'm not a pain specialist. I'm happy to learn this fund of knowledge, but I feel like this is something that may affect your practice, especially if these patients were going to these LAGS medical centers and now they don't really have anywhere to go. I'll let Dr. Zweifler just talk about, I think, an outline of what our pain advisory will contain, to see if there's any other topics that people want us to do a deeper dive on. And then hopefully I'll just be taking notes if there's any other questions. And with that, let me let Dr. Zweifler take over and see if there's any other comments.
Yeah. Thanks, Dr. Vohra. So I'm not a pain management specialist either, but I've certainly seen patients who've been prescribed opioids, and I have, as a primary care clinician, I think most of us have been in that situation. So as Dr. Vohra mentioned, we're facing a bit of a crisis in that I think a lot of primary care physicians have gotten in the habit of referring patients to pain management specialists. There's not a lot of them out there, and really LAGS was one of the only ones. There are some anesthesiologists who do it, but they're few and far between. My feeling, and I think if you read some of the CDC information, is that really it should be more of a primary care disease. That pain, that chronic pain is a chronic condition, and it's one that primary care clinicians, and I would say myself as a family physician, are really in as good a position as anyone to help address those issues. So just, some of the issues that are involved, in terms of, how do you evaluate someone with chronic pain? Well, it's similar to what you would do with any other patient that presents to you. Getting a good history. Certainly you want to, these are chronic issues, so you want to have a good sense of how it started, and who have they seen for this? Have they seen specialists? Have they been evaluated? Have they had x-rays? Any work-related issues? Because one of the things that makes it so challenging is that often there are secondary issues, such as medical legal issues related to work and disability. So getting a careful history on that information, I think, is important. trying to get old records where they're available so that you can be clear and consistent in the care that you provide is essential as well. And then, going on to the physical exam. So chronic back pain is a really common etiology for chronic pain. So, focusing on whatever the area of pain is. But I think it's important to really document any type of objective evidence that is available in terms of that's related to the pain. So what makes pain so difficult is it is inherently subjective. They're letting you know how they're feeling, but as a clinician, you're looking for what type of physical evidence is there to support that is consistent with the complaints. And if there's no kind of verifiable information on the physical exam, it makes you're certainly going to be less comfortable in prescribing long-term opioids or pain medications. Without getting into specifics about exams, thinking about the assessment. So when you see someone who's been treated with opioids in the past or for chronic pain, are you obligated to continue the opioids? Well, no, you're not. But you should be, as I'm sure you're aware, that if you stop them abruptly, there's going to be issues with that as well. But if someone is looking to get pain medicines, you're not obligated to fill those. There's alternatives. Certainly the NSAIDs, various behavioral approaches as well. If you do have a patient and you feel who you evaluate with chronic pain and you feel like that opioids are not indicated, my advice is you should let them know that. And but you shouldn't, if you're abruptly discontinuing them, then that's an issue. And so you can taper patients off of pain medications. And so the common kind of taper that you can use if someone's one of the more common opioids I use is Norco. So if they're on 4 Norcos a day, you say, okay, well, this month we're going to give you 3 Norcos a day. And the next month we're going to give you 2 Norcos a day. And the next month we're going to give you 1, and then we're going to stop it. So you develop so you can let them know up front, this is our plan. We're going to be gradually tapering you off. We're not going to do anything abruptly, but you are not comfortable with prescribing those opioids a long term. Now the patient always has the option to go see someone else, but I think it's a good rule of thumb for clinicians to be consistent in how you approach patients. And so the patient doesn't have the kind of doesn't present in a way that you're comfortable with, you should let them know that. But your notes should reflect the reasons, what the basis for your decision. And that's why it's so important getting old records, doing a careful history on physical exam. Is there objective evidence disease that's severe enough to justify the risks of opioids, which include misuse, abuse, overdose, and death. So they're significant.
I think what's exciting about this space, and something that, depending on how much time you have, there really are a lot of alternatives to opioids. In fact, this whole movement is called ALTO, which is, it stands for Alternatives to Opioids. And new things are being researched all the time. Whether that's different types of injections to, ketamine, Neurontin, gabapentin. There's a lot of other non-opioids that people are trialing. And I think that, there is still more room for innovation in this space, but it's really exciting. It's very interesting pharmacology. And there is real hope for, you don't have to feel like opioids are your only option for a patient that's experiencing pain. There's actually probably a lot of value to multimodal therapy. And that's something that probably we all should be more familiar with, so that we're not just reaching for opioids. I know in the emergency department, this is, a constant struggle but I'm sure in primary care that, we're always, we kind of have a love-hate relationship with opioids. They're so darn good at taking away pain, but they're so darn bad with all of the other complications that they cause. And we just have to be careful with how we use them, but also know that there's many other multimodal approaches that we can use.
Yes, certainly. And in terms of if you do prescribe opioids, there certainly are things that are expected of you if you're prescribed on a chronic basis. So checking the cures to make sure that the individual has been using the medications that are prescribed appropriately, that they're not seeing multiple providers. If you are prescribing opioids on a chronic basis, you're expected. Well, initially you're supposed to check cures if you're writing a prescription for opioids, but then if you're on them chronically, you're expected to check them every 4 months. That check cures at least every 4 months. If you have a patient who's on chronic opioids, then it's expected that you have some type of a pain contract with the individual that's signed by you as well as the patient. Some type of drug screening is recommended by the Medical Board of California to be done, they say, periodically. So you have some flexibility in the frequency of that. I think most folks generally will see folks back who are on opioids on a monthly basis to prescribe the medications. So those are they're. I think we've seen the pendulum swing in different directions where there was a lot of misuse and overuse of opioids. But now we're seeing an incredible amount of attention being focused on prescribing opioids, and so I think a lot of clinicians have tried to avoid doing it at all. And so some patients with even legitimate pain are not getting the medications they need. And so when we talk about chronic pain, it's really for more of the chronic conditions that are causing pain, for things like palliative care, cancer, malignant pain. Certainly, we should be prescribing as much medication as needed to alleviate the patient's discomfort. What are some of the things that you should be particularly concerned about? So again, as thinking of it as a primary care disease, we don't take care of everyone with heart failure. We don't take care of everyone with COPD or diabetes. So you should have access to a specialist when needed. So what are some of the red flags? Well, if you have someone who with a history of substance use as well, then that's a tricky situation. Are they on high dose opioids? So are they over 50 morphine milliequivalents? Might be someone that you might think about getting help with. Are they on multiple psychoactive medications? So they're on benzodiazepines as well. That would be another one that you might think about getting some assistance on. And someone who, despite being treated, continues to need escalating doses, that would be another situation where you might look for assistance. So I think that the bottom line is that we really should be thinking about chronic pain management as more of a primary care condition, and approaching it that way, so that we do a careful history, do a careful exam. We make sure that, and we're particularly careful about getting old records in this situation. Within carefully selected patients, yes, we can prescribe opioids. If we do it, we need to make sure we're doing it carefully, have a pain contract, check the cures, do a periodic urine drug screen. But in that situation, we can prescribe the medication. But if they're at a higher risk, then we would think about referring those individuals. So I think if we look at it from that way as more of a balanced approach, we can take care of 80% of the cases. There's some that we're not going to be able to manage, but that this should be something that's in our armamentarium. The other element to consider is the role of buprenorphine. So that is another medication that is more readily available. And I think Dr. Vohra talked about this before, and he's a great advocate for clinicians to get their waiver X certification so that they can prescribe buprenorphine. Now the is it FDA or CDC? I'm going to forget which branch is actually oversees that, but
yes, yeah, it's SAMHSA, which is an arm of the HHS,
okay.
And the DEA. But you know, it used to be you had to take an 8-hour course to get your X waiver, and the Biden administration in late April said, you know what, the course is no longer necessary. Just go ahead and register and get your X waiver. So now it just takes 5 minutes. It's kind of a painful government website, but it only takes 5 minutes. And then you can get your X waiver. And then you can actually start to prescribe buprenorphine, which is, you know, a fantastic medication for medication-assisted treatment, and also a great pain medication. It's really up there with anything else that palliative care uses in terms of its ability to help with chronic pain. So just consider that, that even though it's a little bit of a hoop to jump through, it really opens up your options for providing opioid level pain relief without the risk of overdose and respiratory depression, that's the real appeal of Suboxone, which is now generic, is that you can now provide that. And this is really going to take the place of methadone. You know, it's so much safer, so much easier to give to patients to go home with. That, you know, whereas before the only option that we had for people that were suffering from opioid use disorder was methadone maintenance treatment and having them go to a methadone clinic every single day. Now we can give them Suboxone to go home with. The risk of overdose is minimal. The risk of respiratory depression is minimal. And they feel very controlled in terms of their cravings and in terms of their pain with Suboxone. So to me, we've had a lot of success with our bridge program at CRMC using Suboxone as the centerpiece of that program. But I'm sure that there's a lot of other people that could benefit from using it. And so please reach out if we can help you with any of that. Getting your X waiver, getting started on Suboxone, getting some clinical coaching so you know you're selecting your patients properly. But this is really the way forward. And that's why, even though this is a crisis, which is why we're having this conversation, there's some real opportunities for all of us to really elevate our game and do some great things for on behalf of our patients that have pain or opioid use disorder.
Yeah, so it's both for folks who have a history of heroin injection drug use in terms of that they want to stop, but also for individuals who are on high dose of opioids and don't want to continue to do that. That Suboxone is a great alternative, and with relatively straightforward dosing and prescribing, and so it's something that you can get used to prescribing relatively quickly. So yeah, you know, for myself, when I'm seeing individuals with pain, chronic pain, I do try and identify, is there objective evidence disease that's severe enough to justify the risks, and really focus on that to help sort out and to feel more comfortable in prescribing and for more complex patients, you certainly can say, hey, they're going to need a specialist. But if we are more open to evaluating these folks, being willing to see them, if you are not comfortable treating them, considering doing tapering, but if they do have legitimate pain, we should be able to prescribe opioids if necessary. And consider Suboxone for folks who want to get off it. So again, it's something that as primary care clinicians we can and should be able to do, and it's a huge area of need in our society, and particularly acute issue right now. So.
Thank you, Dr.
I'll stop there. Yep.
I'll add just one more postscript to your comments. And remember, we're working on an advisory that will have all of these links and all of these best practice tips to help you. But the postscript that I want to add is Narcan. And really, Narcan is something that we know saves lives whenever people have opioid overdose. And we're really used to using Narcan in the emergency department and in the ambulances. But really the new thinking about Narcan is that this really should be seen like an EpiPen, and that, when patients are at risk of death from opioid overdose, it's at the same, the timing is really exactly the same as people who are at risk of death from anaphylaxis after a bee sting. And really it makes a lot of sense to have Narcan in their house, in their purse, wherever they are at risk, so that they can receive Narcan even before the ambulance arrives. And so in the same way, we really want to get people who are at risk, if they need to have opioids in their lives, they should also have Narcan in their lives. And so that's why, the state really reinforced that with legislation that passed a couple of years ago that said, if you are prescribing opioids, you really need to have the Narcan conversation with your patient so that they understand how to reverse the Narcan if they get into trouble. Well, David.
Thanks for bringing that up. Yeah, so it is the law. If they're on more than 90 milliequivalents, if they're also on a benzodiazepine, or if they're considered at high risk, so if someone with a history of substance use, so any of those three situations that you're writing opioids, those are kind of the state law. So yeah.
The barrier to Narcan is that it costs about $150. So that's just way too expensive for many patients to be able to afford. So the state actually has a program that allows you to apply and get naloxone for free, and then you can hand it out to patients, and really to families of patients, because when you think about it, by the time the patient needs Narcan, they're going to be in no state to give it to themselves. So you really have to train the whole family to say, please look out for each other, so that you know how to give Narcan to your loved one if you need to. So I can, I'll definitely include a link to that distribution grant program. Again, it's the right thing to do. We actually just received 1,000 units of Narcan yesterday to CRMC. And that was our second set of 1,000 units because we're part of this Narcan distribution program. And we're happy to share those units. Just request them if you need them. And I actually have a bunch that I'm taking over to Clovis Community Hospital this afternoon, but I'm happy to arrange transport to your clinic if you need some, just to give to your patients that are at risk. But ultimately, we want you to have your own supply. So we'll actually teach you how to apply for your own naloxone distribution program. But again, you can write a prescription, but if the prescription costs $150, there's just no way that patients are going to be able to fill it for the most part. So that's why having it in hand is just such a better strategy for distributing Narcan. All right, we'll stop there and see if there's any questions. As you can see, we really filled up your chat with a bunch of links in case you want to do some reading this weekend. Otherwise, look for all these links in our advisory that's going to come out next week. In the meantime, is there anything, what would you recommend today, John, if there's a provider on our call today or a clinic on our call today and they have a LAGS patient come in, in a crisis mode, what can be done?
Well, it's start with what we talked about, getting a complete history and when did the pain start and who they've seen, and try and get those records from LAGS as a baseline. My advice would be, if someone is on opioids and you check the cures and it shows that they've been on it, then I would consider continuing that. But if you determine that you don't think it's indicated, I think you can tell them that, but you should taper. You can't just stop it. So I would consider a tapering strategy for someone that you were not sure about, and I would probably, given the scenario, I would give them the benefit of the doubt. Say, hey, let's get your records. We'll continue on your medicine for this month. Make sure they've got the Narcan. So that you get the information you need before making a decision. You can say, hey, we're going to review it to determine where we're going to go from here, but give yourself a little breathing room and the patient a little breathing room by erring on the side of continuing the medications that they've been on. But then again, you're not obligated to continue that. If you don't feel it's indicated, after you review the information, do the evaluation, then say after, when you see them back in a month, you get the records, then at that point you can say, you know, I'm not comfortable continuing this. We're gonna start to taper you, or you could offer them Suboxone as another alternative at that time. Hopefully, we'll have other alternative specialists that you can refer to. The health plans are required to have what's called an adequate provider network for each of the specialties. So they have some responsibility. So reaching out to your health plan if it's a complex patient that you're not comfortable with. Yeah, just as any other patient that we see, getting a careful history, doing that exam, getting their old records. In this case, erring on the side of continuing the treatment until you have a chance to have more information to sort out. And then you're not obligated to continue it. If you're going to stop it, taper it. I think that would be doing a service. Yeah.
I was just going to highlight that the managed care plans are aware of this issue. So they should have some contingency plans that they are working on. They may not be perfect, they may not be final, but they've definitely been made aware. In fact, they were made aware before we were at Public Health. So CalViva, Anthem in California, you know, feel free to reach out to them and work with their navigators to help you so that you can hopefully make some at least short-term plans before the long-term plans are put into place. All right, any more questions about that? I know Dr. Z has to jump off for a different meeting, so I won't keep him much longer, but if there's any other questions or comments or really topics that you'd like to see covered in our advisory, like I said, that's my homework for this holiday weekend, is to help finish out what Dr. Z has started. And we hope that we can share that with everybody in the county by next week. All right, and please get your X waiver. If you have a DEA license, it really is 5 more minutes to get your X waiver. So it's definitely worth doing. And I've shared the link for the step-by-step guide, which really just breaks it down to the level of a cookbook recipe. And it makes it very easy to get your X waiver if you just follow that guide from the California Bridge program. All right, thank you, John. The next thing I want to talk about is just kind of an interesting heads up, which is that our environmental health division actually got a very interesting call. And these are never quite the same from episode to episode, but this was a homeowner who found an old jar of mercury in their house somewhere. They were trying to move it, but they unfortunately dropped the jar. This is a very heavy metal, actually. If you fill up a Gatorade bottle with mercury, it weighs about 10 pounds. So it's a very heavy metal, and it was a liquid metal. And they dropped the glass jar, and it kind of spilled all over their property. So this happened, you know, as you can imagine, during off hours. And so they made some phone calls, and eventually the state Office of Emergency Services was alerted, and they actually deployed 2 teams to do like a hazmat cleanup. And these 2 teams are from Northern and Southern California, and they were all going to converge on this person's house to help do remediation and clean this up, because spilled mercury is actually okay to handle with your skin, but strangely enough, it's not okay to inhale. And so whenever you have spilled mercury on a hot day, that actually can vaporize, and then inhaling it actually leads to a lot of systemic effects and toxicity. So the EPA and the Office of Emergency Services has lots of protocols in place to help clean up those spills, because they have to use special vacuum cleaners and special mercury detectors to make sure that it's not getting into a place that will cause chronic mercury poisoning. So our environmental health division was part of that multi-agency response. And Steve Rhodes, who's the director of our environmental health division, was able to help coordinate that along with Dan Lynch. I don't know if you're on, Dan, but that I just wanted to share that happened. Not that it led to any human hazard toxicity, thankfully, but that can happen as a result of these mercury spills. So that just goes to show you, I think it always gives me an appreciation for what our environmental health division does, because they deal with different types of environmental toxins, biological toxins like harmful algae, as well as you know, more chemical toxins like arsenic and lead and trichloroethylene and here mercury. So I'll probably invite them to come do a little bit more formal presentation sometime in the future so that you can understand how environmental health affects human health and how we can work together to improve the health of our communities by innovating in this space. I think it's a really important space to be thinking about. There's some neighborhoods in our county that have a disproportionate burden of environmental toxicity. And it's something that we are sensitive to, and we would love to have more partnership so that we can help address those issues. Because, unlike this case where there was really no human exposure that caused toxicity, there's other cases where we do have lead poisoning and other kinds of toxicity that occurs that could have been remediated or prevented if we'd had better partnership moving forward. So that's something that I'd really like to focus on. As you know, I'm a toxicologist, so this is something that I'm interested in anyway, but I feel like this is something that as a community, we could certainly all benefit from doing more education around. I'm just so proud of this team that I just want to have them have a platform to share the many insights and best practices that they've developed related to environmental hazards. So look for that in the weeks to come. The last thing that I want to announce is that Dr. Al Sagbini, who's with our Department of Public Health, is a specialist in infectious diseases. And he has his clinical privileges at the Kaiser Permanente Medical Center. And he just is such a great educator. And he has a whole lecture about sexually transmitted infections. And so I've asked him to deliver that lecture for us next week. So next Thursday, in lieu of our usual medical providers update, we will actually have Dr. Al Sagbini doing his sexually transmitted infections and all of the updates that the CDC and the state have made in reaction to some of the resurgence of things like gonorrhea, chlamydia, and other sexually transmitted infections. And he's got best practices all bundled up as part of his STIs update. So please look for that next week, and please join us, because I think that will be a really valuable lecture for everybody in clinical practice because so much is changing around that. And this is another epidemic that we really have to redouble our focus on now that COVID is hopefully coming to an end. We really got to talk about some of these other epidemics that are still around and still causing problems. And so I'm so glad Dr. Al is going to help us work through some of those issues. Those are all of the announcements that I have. Are there any other questions? Oh, actually, this is a great time for Mark to come on. Mark Brown is CEO of Madera Community Hospital. CNO of Madera Community Hospital. And Mark, are you available to give us?
Yes, sir. Thanks, Dr. Vohra.
Sure.
So I wanted to give an update to this group. There's a meeting that's set on a lot of calendars for Tuesday, June 1st. That's coming from Cal Hospital. So an acceptance of that would be greatly appreciated. Madera Community Hospital has put in for an emergency authorization for the installation of a new air handler for our emergency department. As you guys are all aware, it gets quite warm here in Fresno and Madera area, and the air handler that feeds our emergency department is on its last legs at best. We have received that emergency authorization from OSHPD, and then as of yesterday, I have received permission from the California Department of Public Health for a program flex waiver of our basic emergency services on June 9th and June 10th, so that we can shut down that service line so that we can replace the air handler. We will not be able to occupy any of that space at all during the time the air handler is down, because we won't be able to have any negative airflow rooms, and we'll have zero airflow going through the emergency department at all. We had looked at the ideas of doing some alternative care sites, whether that be tents or something like that. And we felt that that was not the safest way to treat our patients in Madera County. Treating any kind of codes or 5150s in that environment would not have been safe for our patients or for our staff, especially with the way the temperature is supposed to be getting during that time. So with the blessing of California Department of Public Health, we do have a program, Flex Waiver, for basic emergency services. So we will be shutting our doors for emergency services at 0001 on June 9th and coming back up, worst case scenario, at 10 o'clock on June 10th. So looking for probably a total downtime of between 30 and 34 hours. It's actually only going to take about 2 hours to do the physical replacing of the air handler unit. The rest of it is electrical, plumbing, and then air balancing when it comes to it. The initial 6 to 7 hours will allow us to be able to clear out and either admit, transfer, or discharge any patients we have in the emergency department past midnight. We're hoping to begin construction somewhere between 6 and 8 o'clock in the morning. This will impact a lot of things. It'll impact the 5150s in the county. On average, we have between 2 and 5 5150s here at Madera Community Hospital. So we'll be working with our county agencies around that. I've already spoken with our law enforcement partners and our behavioral health partners here in Madera County about that. We have some more meetings coming up next week to discuss what we need to do with that. And then probably a heads up to Children's Hospital. They'll be getting the pediatric 5150s that we normally get, and to see if they have any more capacity to hit, maybe get some 19, 20, 21-year-olds if we have anything like that. But the biggest impact will be anybody that's coming in for MIs, surgical services, or anything like that. We will not be able to care for that because we will not be offering emergency services for those 2 days. We're going to have information on our website, our social media. We're also going to do a just an ad campaign as well to let everybody know that's in our catchment area that we are not going to be providing emergency services. We will have all of our emergency services, physician on duty signs covered. We're starting to give out flyers as of today. We will still have a full complement of emergency department staff that will be on site during this time in case we do have some walk-ins that will be able to appropriately treat and get 911 out, because once again, we will not have emergency services during this time. So just wanted to give a heads up. I know Dr. Vohra had been talked to by CDPH and got a little bit of a heads up about this, but there'll be another call at 1400 on June 1st from California Hospital Association so that we can discuss some more things. I know Dan Lynch will be on that, in addition to some other people, to just kind of walk through the process and talk through the process. At that time, I'll also share our contingency plan for the emergency department closure so that everybody can see what was approved by CDPH, so that they can feel comfortable with our plan. And we're open to any other suggestions that anybody might have. I have zero ego in this. This is probably the first time that I know of in my 20 plus years in healthcare that an emergency department has shut down for a small period of time. Obviously, UMC, when they moved over to RMC, they shut down that whole thing, but that was completely different. We're only doing it for 2 days and then coming back online. So CDPH was kind of, befuddled with me because they had never done this before. So multiple people smarter than me would appreciate some more advice on how we can work together as a partner during these 30 to 36 hours with little to no impact. Well, there's going to be some impact, but very little impact to the community that we serve here in Madera. Right now, we're averaging about 100 patients a day, 85 to 100 patients a day. So we're not looking, obviously, downtown's numbers or children's numbers or anything like that, but it still will be a rise in patients to the surrounding hospitals. We'll have maps, we'll have everything like that we'll be able to hand out to people, map questing or Googling or whatever they want to do when it comes to getting to the nearest hospital. So we think we have something prepared as long as with some signage that we'll do, some road signs that are flashing ED closed or something to that nature. But just want to give everybody a heads up because we're about a week and a half, 2 weeks out from when we're going to do the closure. Like I said, I would have gone quicker with this or given you guys more of a lag time with this, but we just got approval from CDPH yesterday, and I didn't want to jump the gun and tell you something and then have CDPH not approve our plan. So they have finally approved it yesterday, and so happy to share it with everybody. But unless there's any questions, Dr. Vohra, I really appreciate the opportunity and the time to just give everybody a heads up, and then want to encourage everybody when the invite went out from Cal Hospital, that's regarding us here at Madera. So very appreciative of everybody who's invited can join that. And if you want to forward that on to anybody who thinks should be on that call, the more the merrier, so we can get this out to everybody that's going to be impacted and affected by that.
Thanks, Mark. Thank you so much, Mark. I know that this is already being planned, and I like to say we're in good hands because Dan Lynch has actually had a situation like this before where the air handler had to be changed out. So, hopefully we'll be able to plan for any contingencies and make it a smooth transition for everybody involved. For everybody else on the call, if you're not aware of this planning meeting and you want to be involved, then please reach out to us and we're happy to share that invite to you. And hopefully we can talk more with more updates as they come next week whenever we meet again. All right, thanks, Mark, and thanks everybody else. I think we are at the hour, so if there's no other questions or comments, we'll go ahead and adjourn and let everybody get to their Memorial Day holiday weekend. Please stay safe, stay cool in the hot weather, and have some time to relax with your family. And we'll see you again next week. Thank you.
Thank you, Dr. Vohra.